Thank you, everybody, for joining in. Here's what we're talking about OPEB in 2020, what I'm calling municipal jeopardy. How can we reduce costs and liabilities? So with that, let's get going here. I'll give you the quick 30-second overview of our firms. You know who we are. So we've been around since 1998 doing actuarial and management consulting work. Provide services to about 500 municipalities across the U.S., including about 300 in Massachusetts, offices in Connecticut, Nevada, clients in 37 states, Europe, South America, Australia. So I spend a lot of time on planes, probably once a week. In pandemic times, a little more challenging, but still try and get out there and see clients and people like that. All right, enough of that. So we come to municipal jeopardy. Look, they've cleaned out the board. All they've left us with is compliance. Such fun. So I'll take 1,000 for compliance, Alex. The task I dread doing every 2 years. What is OPEB? So our little tribute to Alex Trebek, who recently left us, is complete. So let's get on to why we're here today. So I'm not going to bore you to tears with all the stuff you guys have heard me talk about over the years. I know most of you are Odyssey clients who are here today. Thank you very much for that. For those of you who aren't, thank you again. I mean, taking the time to do actuarial stuff, I give you credit for that. So whether you're an Odyssey client or not, we're here to help however we can. So what is total OPEB liability? It's just basically the value of the benefits earned to date by both active and retired employees. For the active employees, it's a pro rata share of what they've earned to date by their service versus what the service they will have at retirement date. For the retired members, they've earned all the service they're going to have. So their liability is exactly what it is, the present value of all the future benefits. So we're going to do that. So how do we calculate it? Well, what's the discount rate? Those of you who've heard me speak before know that I have a bit of a problem the way that GASB decides to calculate discount rates, because I don't think they should be based on how you invest your money or the like, but these are the rules we have to deal with. So higher discount rates will get you lower liabilities and vice versa. So when we're calculating a future payment from 10 years, 20 years, 50 years out, we have to bring it back to today. The interest rate or the discount rate is how we do that. So how do we come up with the discount rate? It's not some actuarial mumbo jumbo, wizard and put everything in a pot and stir it around. Rather, there's really 5 key factors. So what are your OPEB assets? How much do you have in the trust today? What's the municipal bond index rate? What's your projected payments? How are you doing? You got 20,000 a year of payments or 100,000 a year of payments or $1 million a year of payments. How are you going to invest the money? Here's the thing. If you put all your money in T-bills, I don't care how much money you have in the trust, your discount rate's still going to be low. My problem with the GASB math is that if you put all of your investments, say, in Tesla stock or emerging market debt or private equity, you would get a higher discount rate. However, I would argue that just because you get a higher discount rate does not mean it's prudent or the right thing to do. So, the means do not, the ends do not justify the means, I guess, being my point. And then the funding policy, probably the most critical of these elements. How much money are you going to set aside every year? If you say, well, we throw in 20 grand, 50 grand, $1 million whenever we have it, that's great. But it's really a discipline, pour the money in every quarter, every year, whatever it may be. That's really what you got to do. Then the question everybody asks, well, how am I doing versus my peers? Well, what you're going to see here is that you're going to see 77% of your people are less than 10% funded. 86% of people are less than 20% funded. So basically, you have a lot of company in being less funded than you would like to be. So, all right, enough of the assumption stuff, because again, ultimately, we can play with assumptions all day long and make your liability whatever we want. But that doesn't change your real costs. So how do we change real costs? Well, here's the thing. In Massachusetts, you are limited in terms of what you can do versus what we do in other states. So changing the eligibility to receive benefits. In Massachusetts, that's state law under Mass General Law. So you can't do anything about that. In other states, we might change it to age 62 and 25 years of service. We might change it, maybe eliminate benefits for spouses or children or people hired before certain dates. Can't do that here. We have to limit the share of retiree premiums. We can't go beyond 50% of the premium. In other states, including, say, Connecticut, it's very common to have 100% of premiums paid by retirees. New Hampshire, places like that. Section 18, hopefully most of you have done this by now, but basically what that says is Medicare eligible retirees have to move to Medicare supplement plans. Hopefully you've done that, as I mentioned. The prescription drug formulary and the benefits under Medicare supplement plans. we'll just give you an example. If you're using Blue Cross, for example, if you're still in MedX3 for your Medicare supplement plan, you could go to MedX2 and have significant easy savings. Now, again, it's a change in benefits. It's a reduction, let's be honest. But it's only going to affect probably 8 to 10% of your population. And yes, they are not going to be happy that some drug that they've used and they like is going to be no longer on the formulary or at a very reduced cost sharing by you as the employer. However, it will save you significant money. We find it'll generally save your OPEB liability by about 20%. So if you make that change, significant savings are there to be had. Now we'll talk about really the two main things I want to talk about today. Look for any retirees who are over 65 and remain in the active plans. So you've got Jimmy or Mary, who was a teacher back in the early 1980s, hung around for a long time. They left. They never paid into Medicare. There are things you can do to basically buy them into Medicare coverage, which will significantly reduce your costs potentially. Also, Medicare Advantage plans, not real common in Massachusetts. We see them in other places around the country. They may make sense for you, but you just have to understand what they are. So let's just boil down the lovely actuarial stuff to just a one-person plan. I know you guys all have 100 employees, 50 employees, 10,000 employees, whatever it may be. And it sounds like I don't understand how any of this stuff gets calculated. So let's just boil it down. We have one 65-year-old retiree, no spouse. He or she, we have an $800 a month HMO premium, $400 a month Medicare supplement plan. We're going to assume a 5% discount rate for this calculation. Our healthcare trend, for those of you who've worked with me for a long time know, we came down to 4.5% about a year ago. I acknowledge it took me a long time to come down there as a firm. We've struggled with that. I know we were higher than that for a long time. I know there are some firms that are down there in the 3.5% range. I have a tough time justifying that. I know Standard & Poor's, when we talk to them, they have a problem with anything below 4.5, and I tend to agree. And again, we're using 25% premiums here for the retiree cost sharing. So when we do that, you'll see here that I'm not going to bore you with all the math, but if you want to look at the presentation, feel free. But in this case, the retiree does not have Medicare. They were one of those older teachers that I mentioned, never enrolled in Medicare, never paid in the premiums. So you're saying, well, gee, we only charge $800 a month. That's a $9,600 HMO premium for the year. The problem is because of their age, their claims are really about $18,000 a year because that HMO premium is actives and retirees combined to create that premium. This is the place when you hear your actuary talk about implicit cost because the premium that you're charging them is $9,600, but their actual cost is more like $18,000 and change, which means that you as the employer have about a $16,000 liability for that 1 year. We discount that all back to today. That's about a $475,000 liability for that one retiree. Now let's take that same retiree and say they're in Medicare. Under this scenario, their premium drops to $4,800. Their premiums, because again, it's all the age 65 plus people are combined, their actual costs are only about $3,500 and change. Over time, their total liability is about $76,000. So as you'll see on the next slide, without Medicare, we're at $473,000. With Medicare, we're at $76,000. So again, Medicare wants to pay about 80% of the bill, and you're saying, no, we're good, we'll pay it. Here's the thing. You can go to CMS and negotiate with them to buy Medicare Part A premium for these people. I'll talk about this in the next slide. How these people, you say, well, come on, everybody's eligible for Medicare. How are they not eligible? Well, as I mentioned, if they were employed prior to 1986 and they've stayed in employment and they're in a public retirement system, they may never have paid into Medicare. So in that situation, you can buy into Medicare. You go to CMS and you say, listen, I want to buy Medicare Part A for Jimmy or Mary. And you want to do that. Now, under Mass General Law, you have to pay for that. You can't make the retiree pay for that. But you will pay the Medicare Part A, you'll pay the Part A and Part B penalties, and then the retiree can then purchase Part B just like all the rest of your retirees. They can also then purchase the Medicare supplement plan. Then you go, yeah, but this Part A, it's $400 and change a month maybe. The penalties might even be $100, $200 a month. I'm going to pay $600 a month. That's $7,200 a year. It's cheaper to just pay the HMO. The HMO is only an extra, $4,800 a year beyond the Medicare supplement under this example. But here's the thing. That's only because you're not counting the implicit cost. When you factor that in, your cash savings in terms of the actual reductions you're going to get are probably in the neighborhood of about $12,000 a year, even after all the penalties. So if you're self-insured, this is a layup. If you're not self-insured, you need to talk to your healthcare consultant, because the way that this works is that basically what's going to happen, we're going to go purchase, we're going to identify all the people, see who they are, review if they have any partial credits. Maybe they worked part-time jobs. Maybe they, somewhere along the lines, they picked up credits. For the people in the GIC plans, if you're in a GIC plan, this is not going to work for you. Your retired teachers in a GIC, this is not going to work. But you talk to your healthcare consultant, you identify these people. And again, the reason why you do this is because in theory, we're taking all of these retirees out of the active retiree pool. When we do that, your active premium should come down. If it's not going to come down, don't do this. But again, talk to your healthcare consultant. We've been seeing for people that are doing it, their healthcare premium for the actives generally drops by about 2%. This slide is something that comes out of our report. If you're an Odyssey client, you've seen this slide before. We just identify, you have, in this case, this client has 78 retirees and spouses over the age of 65 who are still in active plans. For those 78 people, it's about a $44 million liability. Had those people been in Medicare, it'd be closer to a $5 million liability. So they have a potential $39 million in savings before the penalties. So after penalties, we factor those in, maybe it's about $30 million, once we find out what those penalties are. For most of us, that's real money. Again, every organization is different. Again, why you need to talk to your healthcare consultant. But if your actuary doesn't provide you this kind of information, I suggest you ask. It's the kind of thing you're going to need or want when you talk to your healthcare consultant. All right, so enough of that. Now let's talk Medicare Advantage plans. You're saying, I've heard about these things. I see all the ads from Humana on TV all the time. They're on all the time. So a Medicare Advantage plan, also known as an egg whip, these are group plans. These are things that you as the employer can offer. A lot of private companies offer them. Unions may offer them to their employees or groups. They generally offer more benefits than traditional Medicare. But here's the thing. They're generally a PPO. So in other words, they have a limited network. Medicare allows you to go to any doctor you want effectively. The PPO says if you go to doctors in the network, you get a better price than if you go to doctors outside of the network. So we've had a couple of our clients in Massachusetts be offered these Medicare Advantage plans, and they look extremely attractive. Oh, the premiums are so much less. We should just do this. And I'm not saying you shouldn't. It's perfectly fine so long as you understand what you're buying. So the idea here is you have a limited network. For those of you old enough to remember the early 90s when HMOs started to become a much bigger thing, we ran into the same issue here. We go, oh, we'll go to HMOs. We can save all this money. And they go, well, how come my doctor is not covered? The reason we get the savings is we selected doctors who will give us better pricing. They do that in exchange for volume. So the same thing here with the egg whip. So here's the thing. In an egg whip or a Medicare Advantage plan, they have to offer all the same services as Medicare. It's not like they can pick and choose. They can offer more than that, but they cannot offer less than that. The idea, what happens here is they go to Medicare and say, listen, we're going to take these retirees off your books of Medicare. You guys will write us a check and we will take care of these retirees. So they are off traditional Medicare and they come over to the egg whip. So it still covers Part A, which is all your hospital insurance, your Part B, which is the doctor visits. They'll have the Part D, which is prescription drug. They might offer other things like dental, eye exams, podiatry, things like that. And sometimes they may even offer things for your dependents of retirees. So again, they're not obligated to. Each egg whip is different. So you got to look at these things. Again, they may make sense for you. We see them very commonly. I just did a big plan in Michigan last year. We put in this and basically moved all the retirees to the egg whip and they saved a lot of money. I've seen it in corporate America many times over the years. So it can definitely work. But again, you have to understand what you're buying. With that, we have questions available if you guys want. Here's my contact information. You're welcome to reach out at any time. I know, again, most of you are already Odyssey clients. You know how to do that. But even if you're not, you just want somebody to come out and talk to your group, explain one of these things, that's fine. We're happy to do it. So at any time, reach out and we're here to help. Thank you again for the time. And if we can do more, just ask. Thank you.